Welcome again, everybody. Our discussion here is going to be on thyroid disease in pregnancy. Thyroid disease has a complete interaction with the pregnancy process. So not only can thyroid disease affect the course of the pregnancy, but it can also affect your ability to get pregnant. And then you can also get thyroid disease as a consequence of pregnancy in the postpartum period. So there is a complete spectrum of relationship between the thyroid and the pregnancy. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below or on the I button on the upper right-hand corner of the screen. If you could consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. And if you do subscribe, you'll have access to some of my premium videos in which I go over case studies, forming a diagnostic battery, treatment plan. All those things will be very useful to you, both for clinical practice and if you are gearing up to study for step 3 of the medical licensing examinations here in the United States. They will have clinical case scenarios which are not multiple choice, and you'll need to understand how to do that. Also, I suppose to a lesser degree, step 2 CS will have you do that as well. So we're going to briefly review the normal thyroid physiology, which I go into at length in the endocrinology talks, the changes which occur during the pregnancy, which I talked about in previous OB talks, and then the thyroid function in the fetus. Not going to go into too much detail here because that's more a topic of pediatrics. We'll talk about both hyperthyroidism in pregnancy and hypothyroidism in pregnancy. And then, of course, any talk of thyroid disease in pregnancy would be incomplete if we didn't talk about the postpartum period, because that is a key point of the pregnancy, the postpartum period. And here we have postpartum thyroiditis, which, again, I also talk about in the endocrinology section. So the thyroid functions on an axis with the hypothalamus and the pituitary. So the hypothalamus secretes TRH, I believe thyrotropin-releasing hormone, and then that stimulates the anterior pituitary to put out TSH. TSH is a very important hormone because it is what we measure when we're assessing the function of the thyroid. We want to know is this a problem of the thyroid or is this a problem of the pituitary? TSH acts on the thyroid. Thyroid puts out two hormones which are interconvertible. That's T3 and T4. These thyroid hormones have a wide variety of activity. They work on pretty much every type of cell in the body. They do things like increase the basal metabolic rate. They act synergistically with growth hormone to increase long bone growth. They help the CNS mature. They increase sensitivity to catecholamines. They increase body heat. They regulate metabolism of macronutrients like protein, fat, and carbohydrates. So they do all sorts of things. Really the jack of all trades of hormones. T3 and T4 can work backwards on the hypothalamus and pituitary. You have a negative feedback mechanism. So if you're making more T3 and T4, you tell the hypothalamus and pituitary to slow down, and that's going to reduce your TSH levels. And that is a good thing because we don't want this to propagate itself to infinity. So during pregnancy, we have an estrogen-driven increase in TBG. And what TBG is it's a protein which binds thyroid hormone. So as I said, this is driven by estrogen which comes from the placenta. And so you have this TBG and it binds T4, and T4 cannot work if it's bound to a protein. It can only work if it's free. And so if you have more TBG, you have more bound T4 and you have less free T4. Well, there's a nice way to get around that. If you have less free T4, then you have less negative feedback on the hypothalamus and pituitary, so you'll make more TSH, that'll act on the thyroid, and you'll put out more T4. And so all of that is well and good. The net effect is that the thyroid hormone level stays roughly the same, and the TSH level stays roughly the same. Now another thing that comes on here is that the placenta makes HCG. And HCG shares an alpha subunit and has similar beta subunits to TSH. And so HCG has some thyroid stimulating properties to it. And that's going to come into importance when we talk about one of the causes of hyperthyroidism in pregnancy. All right, I think that's all I want to talk about here. I think there was one other thing. It's not coming to mind right now. So I will leave it at that. Very important to suspect thyroid disease in the workup of women with repeated miscarriages. Hypothyroidism and hyperthyroidism both increase your risk of miscarriage. Also very important, just for an infertility workup, to suspect thyroid disease. Subclinical thyroid disease is a possible cause. You're always going to get a TSH in a woman who's not able to get pregnant or repeated miscarriages, because thyroid disease can be behind that. So keep that in mind. Woman with repeated miscarriages, one of the things of many that we're going to check out is her thyroid function. Okay, so that is just that picture blown up here. So as far as the fetus goes, the first trimester, there's really no function. The baby has no thyroid function whatsoever. Around the beginning of the second trimester, end of the first trimester, the fetal thyroid does begin to make, actually I should say the fetal pituitary begins to make TSH around 10 to 12 weeks gestation, and then the thyroid starts to put out thyroid hormone towards the end of the second trimester. Okay, so the fetal anterior pituitary begins to make TSH around the end of the first trimester. And you get some, just gradually more thyroid hormone. And it doesn't really, though, become appreciable until towards the middle end of the second trimester. And so what this means is that in the first trimester, because the baby's not making any thyroid hormone whatsoever, the fetus is heavily reliant on the maternal thyroid hormone. So if there are issues with the maternal thyroid, particularly hypothyroidism, you're really going to see those effects in the first trimester of development. Maternal TSH does not cross the placenta. So even if the baby's thyroid were properly developed, you're going to run into problems if the maternal thyroid hormone levels are not what they should be. So you need the maternal thyroid hormone levels to be proper. So thyroid hormone can cross the placenta. Another thing that can cross the placenta is the thyrotropin receptor antibodies. And that's one of the things that we see in Graves' disease. So we'll see that neonatal Graves' disease is a real thing. So hyperthyroidism affects about 0.1 to 0.4% of pregnancies, which doesn't sound like a lot, but if you do 1,000 deliveries a year, then you're going to see this. Any cause of hyperthyroidism can occur during pregnancy. So Graves' disease is the most common, but you can also see subacute thyroiditis, you can see toxic multinodular goiter, you can see toxic adenoma. So any cause of hyperthyroidism can occur superimposed upon pregnancy. But the most common cause of hyperthyroidism in pregnancy is Graves' disease. The symptoms of hyperthyroidism in pregnancy are exactly what we see in everybody else. Weight loss is the big one. In pregnancy, this is going to be all the more recognized because should you be losing weight in pregnancy? No. Should you be staying the same weight in pregnancy? No, you should be gaining weight in pregnancy. Singleton pregnancy, we expect 1 to 5 pounds of weight gain in the first trimester and then 1 pound a week after that. So if she is not gaining weight, then we have to consider a possible etiology behind that. And you want to ask her, how's your appetite? If your appetite is bad and you're not gaining weight, well then that may be the cause. But if she's eating chicken wings every day and she's not gaining weight, then you may have your answer here. Heat intolerance, that's a classic one to come up on the test. Sweating, dyspnea, tremor, anxiety, tachycardia. Those are the big ones you want to know for hyperthyroid symptoms. Graves' disease, we can also see a few other symptoms. You can see ophthalmopathy, basically signs in the eye. Things like lid lag and proptosis. You can see myxedema. Myxedema is sort of rash, and you'll particularly see it on the front, on the shins, on the leg. And it's just a sort of red-looking rash. And then goiter. So we don't expect to see goiter in HCG-mediated hyperthyroidism, for instance, or you don't really see goiter if you have nodules. But to have this diffuse goiter, you can see it in Graves' disease. Not all of them, but in a decent amount, you can see a goiter in Graves' disease. We don't see that in the other common cause of hyperthyroidism. And that brings us to what is that other common cause of hyperthyroidism? Along with Graves' disease, you have something called HCG-mediated hyperthyroidism. And all that means is that HCG is acting on the thyroid and causing it to make more T3 and T4, which then causes symptoms. Now, typically, HCG always works on the thyroid. It does always work on the thyroid. But the degree is the question. So if you have more HCG for one reason or another, let's say you're carrying twins or triplets, then you can get hyperthyroidism from that because you have more HCG acting on the thyroid and now you're making more T3 and T4. And then there is another cause where you're making too much HCG, which we'll discuss in a little bit. Okay, so Graves' disease and HCG-mediated hyperthyroidism. Our initial workup is going to be a TSH and a free T4. This should be your basic workup on anybody who you're suspecting hyperthyroidism. And what do we expect to see? Low or undetectable TSH and a high free T4. And all this is telling you is that the thyroid is acting independently of the anterior pituitary and is secreting excess thyroid hormone. So our further workup then is, well, it's our next question. So we know she's got hyperthyroidism. Well, what's the cause? Well, we know that the two common causes of hyperthyroidism is Graves' disease and HCG-mediated hyperthyroidism. Now, assuming you did a good physical exam and you didn't feel any nodules or anything, we can rule that out, and we're down to two things. And so you get this thyroid receptor stimulating antibody, also known as thyrotropin receptor antibody. And if it's positive, you have Graves' disease. If it's negative, then you have to assume other causes. And those other causes, usually HCG-mediated hyperthyroidism. And there are different variants of HCG-mediated hyperthyroidism. You're not going to be asked that on the test. So this is lid leg. So we see some connective tissue issues with Graves' disease. And it affects the connective tissue surrounding the orbit. And so one of the things that you can see is that the lid gets kind of retracted a little bit. And if you have the woman look down, normally we expect to see the lid to kind of go down with it. If she has lid leg, that lid will kind of stay fixed in its position. And that can affect both eyes, or it might affect one eye more than the other. This is a more dramatic symptom that we see with Graves' disease. And so what's basically happening here is that the connective tissue around the eye is changing in its structure, and so the eye is bulging out a little bit more. The eye might be actually bulging out a little bit too, but it's mostly an effect of the connective tissue surrounding the eye. And so this is exophthalmos or proptosis. And you have to be really careful because not all people are going to have this dramatic, obvious of a presentation. So you just want to, you might ask her, people know themselves better, because they see themselves every day. They know themselves better than you do. So you'll want to ask, do your eyes look any different than usual? You can compare it to previous pictures. Everybody's taking selfies these days, so you can compare it to previous pictures and you may notice a slight difference. Or it may be more obvious. So the question, when it's between Graves' disease and HCG-mediated hyperthyroidism, of course, getting those labs are a very definitive way of determining what it is. But there are some clinical clues as well. So patients with Graves' disease will usually have a personal history of hyperthyroidism, whether it was diagnosed as Graves' disease or not. Because with HCG-mediated hyperthyroidism, because it's HCG-mediated, they're not going to have it before the pregnancy because they didn't have HCG before the pregnancy. Or the patient with Graves' disease may have simply been diagnosed with Graves. And Graves, although it's supposed to get better during the pregnancy, theoretically at least, it's supposed to improve somewhat during pregnancy, it can manifest during the pregnancy. So maybe they were diagnosed with Graves and for some reason now they're having symptoms. Obviously, a previous history of Graves and now you're having thyroid symptoms, it's probably from the Graves' disease. There are also often unique features that we see with Graves' disease that we don't see in the other types of hyperthyroidism, which we already talked about, things like lid leg, proptosis, goiter, etc. HCG-mediated hyperthyroidism has one really big clue, and that is that it occurs during the first trimester and goes away on its own. Why do you think that is? So I'll give you a hint. It's in the name. HCG mediated. What happens to your HCG levels during pregnancy? When does it peak? It peaks towards the end of the first trimester and goes away. What else do we see with HCG that gets worse? The worst it is towards the end of the first trimester, and then it goes away as the pregnancy progresses. Hyperemesis gravidarum. And there is a link between HCG-mediated hyperthyroidism and hyperemesis gravidarum. Remember, hyperemesis gravidarum, it's not just morning sickness. This is really bad morning sickness associated with a weight loss. So this is nausea and vomiting accompanied by a greater than 5% weight loss. So these two are often seen in consort. So if you have a patient with hyperthyroidism who also is vomiting a lot, you may want to consider that there's the hyperthyroidism there present as well, and not just send her off on her merry way with a diagnosis of hyperemesis gravidarum and some anti-nausea pills. You will certainly want to check her thyroid levels as well if she's coming in with really bad morning sickness and weight loss. And then there's also a link with GTN, gestational trophoblastic neoplasia, and it's probably causal from the GTN, because with GTN you have really high levels of HCG, and so all that HCG can then affect the thyroid inevitably and cause hyperthyroidism. And hyperthyroidism is a consequence of GTN. And I should say, GTN is not pregnancy, but it's caused by conception. Okay, so I put it in here, but if you do an ultrasound, you're going to see that she's obviously not pregnant, or if there is a fetus, it's not viable, depending on the type of GTN that she's got. But it is associated with, conception, so I thought I'd include it here. The treatment goal of hyperthyroidism in pregnancy is to maintain persistent but mild hyperthyroidism in an attempt to prevent fetal hypothyroidism. So we have a balance here. We don't want to over-treat her, but we don't want to under-treat her. And what we found is that the happy medium is a mild hyperthyroidism. That if we go too far and even bring her into euthyroidism, it can actually have negative consequences on the baby. So mild hyperthyroidism is our balance point. So we want to get her TSH levels up to a point where it's just on the low end of normal or even slightly below normal. Where she's not having symptoms, her hyperthyroidism is improved somewhat, but we want there to be somewhat of a mild hyperthyroidism because we don't want to treat too much. That is a very big possibility. If we can have serious consequences if we treat too much. So we're always looking for that balance. Fetal hypothyroidism, for different reasons, may result if maternal hyperthyroidism is undertreated or overtreated. And so that's why we've decided that we want to have her at a mild hyperthyroid state. So we want that TSH to be at the very low end of normal or even slightly below the low end of normal. Neonatal Graves' disease, we're not going to talk about a whole lot here because this is a pediatric issue. But this occurs because those thyrotropin receptor antibodies can cross the placenta, go into the bloodstream of the baby. Now the baby does not make antibodies of their own, but they have the maternal antibodies. And if they have maternal antibodies that cause Graves' disease, what do you think is going to happen to the baby? They're going to have Graves' disease. Now that Graves' disease is not permanent. After 4 or 5 months, those antibodies get cleared out. But neonatal Graves' disease is a real thing, and it just happens because they're inheriting antibodies from mom. Management, not necessary for HCG-mediated hyperthyroidism. So if you don't have Graves' disease, it's HCG-mediated hyperthyroidism, no need to treat. You have a woman coming in, first trimester, she's 10 weeks pregnant, she's got all the signs of hyperthyroidism, just mild signs of hyperthyroidism. You don't need to treat. As long as you get her thyrotropin receptor antibodies and it's negative, you know she doesn't have Graves' disease, it's HCG-mediated, no need to treat. Indications are going to be moderate to severe symptoms that are secondary to Graves', toxic adenoma, or toxic multinodular goiter. The cornerstone of treatment for hyperthyroidism and for hyperthyroidism in pregnancy are the thionamines. And that is a class of medications which includes PTU, propylthiouracil, and methimazole. Methimazole is how it's commonly referred to, but it's technically carbimazole, and carbimazole is what's given, and then it's converted in vivo into methimazole, which has antithyroid properties. So here's what I want you to take from this. This is important. When she is in her first trimester, up to 16 weeks, so slightly into the second trimester, she needs to be on PTU. You cannot give her methimazole early on in the pregnancy because of the teratogenic effects. So she needs to be on PTU during the first trimester up to 16 weeks. After that, after 16 weeks, then you can switch her to methimazole. Or she can just continue to be on PTU. You have an option. But during the first trimester and up to 16 weeks, she needs to be on PTU. PTU only during the first trimester and up to 16 weeks into the second trimester. The adverse effects of PTU, there are slightly more, and so that may be why you want to switch to methimazole when you can. With both PTU and methimazole, you can get neutropenia, but with PTU, you can get aplastic anemia. There's some pretty nasty things it can do to the liver, theoretically. It doesn't happen very often, though. So I would stick to PTU in pregnancy if the test asks you, but you can switch to methimazole, but only after 16 weeks. Symptomatic treatment, this is important because if a woman comes in with real severe hyperthyroid symptoms, this is your first treatment. Okay, so if she comes in, you get a test question that asks you, what's the first thing you do? And she's got hyperthyroidism, and it's very obvious, and you ran labs, and she's got Graves' disease. The first thing you do is treat her symptoms, because if she's got tachycardia and she's got let's say she's got some kind of arrhythmia, you need to treat the tachycardia. You need to treat her symptoms first, and so you give beta blockers. Now, again, here, it's a a benefit drawback sort of deal here. You don't want to give medications if you don't have to. And so you want to use these judiciously. Beta blockers can have negative effects on the fetus. So you have to be careful. You need to balance the benefits to mom versus the drawbacks to the fetus. So beta blockers are good to give if she's severely symptomatic. But if she's only just mildly symptomatic or not symptomatic, don't want to give beta blockers. So use them judiciously, exercise good clinical judgment. She should be coming in to have her thyroid functions drawn every 6 weeks throughout the pregnancy. Some will do it every month. And you're going to also monitor the thyrotropin receptor antibodies in Graves' patients. Why do you do this? Because her requirements for antithyroid drugs are going to possibly go up as the pregnancy goes on. Usually it does. And so you want to monitor that through the pregnancy, just to make sure that she's well titrated. You also want to monitor her thyrotropin receptor antibodies. That's such a mouthful. In the Graves' patients, because the ones with really high TRABs are going to have a higher likelihood of giving birth to a baby with neonatal Graves' disease. And so you want to know that in advance because you want to monitor the fetus prior to delivery, make sure that the baby is doing well, and also to have neonatology thoroughly on their feet for when the baby's delivered, because this is a serious complication. So on the talk of complications, here's the complications during pregnancy. There's an increased risk of spontaneous abortion, increased risk of stillbirth delivery, increased risk of preterm labor, low birth weight, probably because if mom's not gaining weight, baby's not gaining weight, preeclampsia, and maternal heart failure. I'm not sure exactly why preeclampsia, but there it is. Okay, now what about hypothyroidism in pregnancy? So we don't see hypothyroidism that much anymore because the biggest cause of hypothyroidism we've pretty much taken care of. And so we've taken care of it so much that it's not the most common cause of hypothyroidism anymore. Now, the most common cause of hypothyroidism in the general population, as well as in pregnant women, is Hashimoto's thyroiditis, an autoimmune condition. Now, it used to be, back when my grandma was a little girl, that iodine deficiency was very common. And the reason that this is not so common anymore is for a couple reasons. One, we get iodized salt. And as you know, Americans and Europeans love their salt. So we get lots of salt, and there's usually iodine in that salt. Now, a lot of people are thinking, well, everybody's using sea salt nowadays. It's sort of the craze. People think it's healthier. And I don't know about that. But what I can tell you is that that's probably not going to cause an epidemic of iodine deficiency. Because nowadays, we get our produce in from all different parts of the country or even the world. And it used to be back in the 20s and 30s and before that, before we had iodized salt, you got all your produce from 2 towns down the road. And so because everything was locally sourced, if you happen to live in an area where there wasn't enough iodine in the soil was iodine poor, then you could wind up iodine deficient. But nowadays, you get your corn from Iowa, and you get your wheat from Alabama, and you get your oranges from Florida, and your potatoes from Idaho. Everything comes from all over the place. And so the likelihood, and you don't need that much iodine, so the likelihood that everything you're getting is from an iodine poor area is very low. So those are 2 reasons why we don't see iodine deficiency so much in the westernized world, in the industrialized world. Other causes of hypothyroidism, iodine deficiency, as I mentioned, more going to be seen in the developing world. Prior radioiodine ablation. So let's say she had hyperthyroidism in the past and she had treatment for it. Prior surgical removal, disorders of the pituitary or hypothalamus. Oh, and that's the other thing I wanted to talk about. So let's just briefly go back here to management of hyperthyroidism in pregnancy. It should go without saying, but what do you think about, let's say that the antithyroid drugs didn't work. Can we do radioiodine ablation for these patients? If anytime you hear the word radioactive and pregnancy, probably a no-no. Okay, so you don't want to do that. If we need to do something drastic with hyperthyroidism, getting rid of that thyroid hormone, we're going to do a surgical thyroidectomy. We're never going to give 131 iodine to a woman who's pregnant. Never, ever, ever, ever. It's a great way for a lawsuit. All right. Symptoms of hypothyroidism. So back on hypothyroidism in pregnancy. This is the problem. Okay, this is a big problem. The symptoms that we see with hypothyroidism are very similar to the symptoms that we see in a normal pregnancy. So fatigue, yeah, mom's tired, she's pregnant. Cold intolerance, that can be really subjective. Constipation, very common in pregnancy. GI system kind of slows down, got a big baby pushing up against your intestines, slows everything down, mom becomes constipated. Excessive weight gain, well, what's excessive, right? I mean, it's probably not going to cause you to gain so much weight that you think it's abnormal. Okay, so this can present a conundrum. And so really what it typically rests on is that mom is so tired that she just can't get out of bed in the morning. Or you ask mom how much she's pooping and she tells you maybe once a week. Okay, here is where you will run into your typical hypothyroid cases. But as you can imagine, many patients with hypothyroidism are quote-unquote asymptomatic. And I say quote-unquote asymptomatic because they're probably having symptoms, but they're getting misattributed to the normal things that we see in pregnancy, when in fact she's got overlying hypothyroidism. Our initial workup for anybody who we suspect hypothyroidism is going to be a TSH and a free T4. Very predictable. And what do we see? The TSH is going to be high and the T4 is going to be low. So the pituitary and the hypothalamus are telling the thyroid to work, and the thyroid saying, no, I don't want to work. So our further workup is going to be thyroperoxidase antibodies. What are these associated with? Which condition? Hashimoto's. And so we want to check for the most common cause. If we get a positive titer, then we know we have Hashimoto's. If it's negative, we look for other causes. So there are different people, different organizations, including the American Thyroid Association, who have come out saying that we should maybe get a TSH screen in certain women because it's so difficult to pick up on hypothyroid symptoms during pregnancy. And that's a good idea, because if the woman truly is severely hypothyroid, that can be a big problem for the baby, because remember, in that first trimester, you can have a hypothyroidism, and if it's not very symptomatic, maybe not symptomatic for mom, but baby may be in serious trouble. So for that reason, the American Thyroid Association has come out and said that we should get screening in certain women. And it's so many different classes of women here that it's almost like, well, maybe we should just get in everybody. Who shouldn't we get it in? Maybe the better question. And so they've said consider it in women with family history of thyroid disease. Well, that's a lot of women right there. Age over 30 years. So I don't want to say old women because I'm turning 30 next year. But age over 30 years. So that's about, I would say, probably about 30 to 40% of your women right there. Type 1 diabetes, recurrent miscarriage or preterm delivery, multigravida, that's a lot of women right there. Morbid obesity, that's a lot of women, definitely in this country, fat country we live in. Head neck irradiation, and then use of amiodarone, lithium, that's a big one. And then recent use of iodinated contrast agents. So a huge subset of the population, I would say a majority of the patients. But this comes from the American Thyroid Association. This is not universal, not universal agreement. And so there really are no set in stone recommendations, but I would take this very seriously because TSH is not a very expensive test to get done. And if you consider the possible benefits, if you detect hypothyroidism and what you could prevent from happening, if you detect this in the first trimester, you could prevent some serious problems. So I would err on the side of getting this done. You will certainly not be docked if you are taking step 3 clinical case scenarios and you put in a TSH for a woman who's 33 and pregnant. I don't think you'd be docked by any means. So this is certainly something you should consider. Our management. So all women with a TSH of more than 4 should be treated. And most women who just have an elevated TSH should be treated. So again here, with even these recommendations aren't, they're not very definitive. And the reason is because we don't want to treat women who aren't going to get benefit out of it. And so and this came from Up to Date, I should say, we find is that women who have a TSH more than 4, they're severe enough to where they all need to be treated. But most women with an elevated TSH should be treated. On the test, you'll have a very obvious case. So they'll have a TSH of like 7. And so those patients will be treated with levothyroxine, just like anybody else, Synthroid, which we give to anybody with hypothyroidism. And we want to titrate down to a TSH of 2.5. And we'll recheck that every 4 weeks because her requirements may change as the pregnancy progresses. And then finally, postpartum thyroiditis. So this is considered a variant of Hashimoto's in as far as it is autoimmune in origin. And many of these patients, if you were to draw TPO titers, thyroid peroxidase titers, 60 to 85% of them will come back with positive TPO titers. So this is a variant of Hashimoto's. The difference is that postpartum thyroiditis tends to go away. It tends to resolve on its own. Hashimoto's does not. So what happens here is that you have a lymphocytic attack of the thyroid, and as the thyroid becomes attacked and you get inflammation, those follicles, which contain thyroid hormone, begin to collapse and release thyroid hormone into the bloodstream. And so for that reason, you have a very brief, transient hyperthyroid phase. So we're talking here maybe a week or 2 of a hyperthyroid phase. And they may present during this period, but the hyperthyroid symptoms that you get during that phase of postpartum thyroiditis is not as severe as what you see during Graves' disease. So a lot of times they don't present during this period. Then they'll have a transient euthyroid phase where the levels are sort of thyroid hormone are kind of normalizing. They're going down. Certainly they're not going to present during this period. And then those levels go down into the hypothyroid phase. And what's happened now is that the thyroid has become damaged and it's kind of shocked and it's not going to be able to respond to TSH and put out thyroid hormone. So they're going to be hypothyroid. And this is usually when they present. And then after that, as they recover, then they become euthyroid again. So the symptoms are a small, painless goiter. So they have a small inflammation of their thyroid. It's not painful, and the thyroid symptoms will depend on the stage. So if you have a woman coming in with any kind of thyroid symptoms, and you feel her neck, and you feel that maybe her thyroid's a little enlarged, that's a good indication to do an initial thyroid workup. And you want to get a TSH, and you could add a T3 or T4 onto that if you want. And so I put on here also radioactive iodine uptake. This would be a classic thing that we would want to get on your average person, but postpartum thyroiditis tends to present within the first 3 months after delivery. And a lot of women are breastfeeding during this time. Do you think we want to give radioactive iodine to a woman who's making breast milk and giving that to her baby? Well, would you give radioactive breast milk to your baby? No. So a lot of times we don't do this. We don't do the radioactive iodine uptake test. And another thing is that the diagnosis of postpartum thyroiditis, it doesn't really imply a whole lot. We don't do a whole lot for treatment, and it's self-limited. So how much is that really going to affect what you do? So TSH will depend on the stage. If you did get a radioactive iodine uptake, let's say she's not breastfeeding and you did it, it's going to depend on the stage. So what you do see though, let's say that this is when it would be really useful to you. If she were hyperthyroid, postpartum hyperthyroid, and you got a radioactive iodine uptake, this will help you distinguish it from Graves' disease. Although you may get your TRABS and distinguish it that way, this can help you distinguish it from Graves' disease as well. So with Graves' disease, what you have is an overactive thyroid. You have those antibodies stimulating the thyroid, and the thyroid is just working overtime. And so if you give iodine, radioactive iodine, to the woman, her thyroid is going to light up like a Christmas bulb. And so she's going to have lots of radioactive iodine uptake because her thyroid is just pulling in iodine all over the place. With postpartum thyroiditis, if they have hyperthyroidism, it's not because the thyroid is overactive, it's because the thyroid is damaged and it's spilling thyroid hormone out. And so you're not going to have a high radioactive iodine uptake, you're going to have a low radioactive iodine uptake. It's not because the thyroid is hyperactive, it's because the thyroid is damaged. And so that's one way you can distinguish it from Graves' disease. Now, you probably won't do this in clinical practice, but the USMLE loves stuff like this. So I would understand how the radioactive iodine uptake test works, and if you want to know more about that, you can go back to my lecture on the thyroid and the endocrinology talks and look it up there. So the treatment is really only needed if the woman goes into thyrotoxicosis. So obviously if she comes in and she's got a heart rate of 130 and she's anxious and she's tremulous and stuff like that, then yeah, you'll treat her, you'll just give her a beta blocker. And that goes for anybody with thyrotoxicosis. Beta blocker, observation. But you don't need to do any kind of ablation or anything because this is self-limited. But you'll want to give her a beta blocker and observe her. Usually this goes away in about a year or so. Some more complicated cases, when she becomes hypothyroid, she may become severe enough hypothyroid to where we need to treat her. Usually the cutoff is the TSH exceeds 10, then we'll begin to treat her with levothyroxine. Usually we like to wean them off after about a year because this does go away on its own. And so we'll wean her off after about a year and see if it goes away. And if she has recovered, then her thyroid hormone levels will pick up on their own. If they don't, then she's probably now got real Hashimoto's thyroiditis. So if you have any questions, please write me a note below. Otherwise, I will see you next time.